Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Ibrahim Hassan. I'm a consultant anesthesiologist in Dr. Sulaiman Al-Habib تخصصي hospital HMG. Our topic today is about outpatient total knee arthroplasty, the most recent updates. In the beginning, I want to certify that I have no conflicts of interest or financial support for this presentation. Advanced chronic osteoarthritis, best management is total knee arthroplasty because it's a successful technique, safe, and cost-effective. In this paper, actually, it's a statistical study which is studying the number of total knee arthroplasties in the United States since 1993 till 2000. From 1993 till 2012, and it shows how total knee arthroplasties number is increasing in relation to the US population. And also in the same paper, they are predicting how many total knee arthroplasties is going to be done on 2050. And according to the study expected in 2050, the expected increase will be 143%. Means 1 and 1.5 of the cases we are doing these days, it will be 1.5 more on 2050. In 2018, there was a statement done by American Association of Hip and Knee Surgeons and the American Academy of Orthopedic Surgeons. And in this statement, they said that approximately 5% of all TKRs are performed as an outpatient basic. Now, our question, why we are shifting to outpatient total knee arthroplasty? We used to do total knee arthroplasties as an inpatient procedure, and there is a new direction now to do these cases as an outpatient case, because we are improving our technologies and we have improved techniques. Also, we are growing. There is growing evidence of safety of to do this surgery as an outpatient. Also, the insurers they are have concerns regarding cost. If we decrease the costs on the insurance, they will be able to provide the service to more patients. Also, there is increasing patient demand. On my personal experience, I have seen many patients, they are requesting to go home next day of the surgery. So this is another factor, and increasing hospital care standards. And last thing is we are now living in the era of COVID-19. And in the new era of COVID-19 now, the direction of all surgeries to be done with least hospital stay. And one of these surgeries which everyone is concerned to do it as an outpatient case is total knee. There is this study is a comparison between short stay and long stay of total knee arthroplasties. They are comparing patients who stays 1 to 2 days and the patient stays 3 to 5 days in the hospital. Regarding costs, you see that there is a very, we're speaking about reduction of 20% of cost when we are keeping the patient 1 to 2 days only in the hospital. And regarding safety, after 2 years, they found the patients who stays from 1 to 2 days, they have less pain and stiffness, and patients stays 3 to 5 days, they have higher risk of revision. Inclusion criteria of outpatient total knee. Actually, there is no global guidelines which says who is the patient who is eligible to do this procedure as an outpatient. But there is some efforts done by some centers, and we're going to illustrate some of these efforts. In 2017, Dr. Gromov and his colleagues, they put some criteria to do total knee arthroplasty as an outpatient procedure. One of these criteria that the intraoperative loss should be less than 500 ml, and patient should back to the ward before 3 p.m. Received instructions from physiotherapist, and patient is safely immobilized, and no clinical symptoms of anemia. Also, the pain score is 3 while resting and 5 while immobilizing. Spontaneous urination, and post-operative radiograph is approved. relative or friend, because they are the people who are going to take care of the patients. They stay with the patient for at least more than 24 hours, and there's a motivated and accepted same-day discharge. The patient should be willing that he can go home on the same day of the surgery, and other standards of discharge are fulfilled, no nausea and vomiting, and other criteria are fulfilled, and patient is fully conscious and have fully motor power. And lastly, the patient can be discharged. All these criteria should be made before 8 p.m. If the patient has these criteria before 8 p.m., the patient can go home. Also in 2018, Dr. Giugini and his colleagues, they put some criteria and some factors which, depending on these factors, the patient can go under outpatient total knee arthroplasty. The surgical factor includes that the surgery should be as a primary TKR, not a revision, and also it should be the first or second case of the day. And on the medical factors, the patient age should be less than 75, BMI less than 35, no anemia, no COPD, no congestive heart failure, no venous thromboembolism, no cirrhosis, no BPH, no spinal stenosis, and no chronic narcosis. Also, there is some social factors they put in consideration. There is the patient should be living near to the hospital in case he needs any urgent medical help. He should be near to the hospital, and also there should be a private insurance which covers the cost if the patient needs to be has a complication, and there is some area which covers this cost. Other centers, they are using like a classification and scoring system, which are known as scoring system, which is used to tell us how is the morbidity of the patients. One of these scores is the assessment of ambulatory arthroplasty risk, and the American Society of Anesthesia as a score, and the Charlson Comorbidity Index. The assessment of ambulatory arthroplasty score is like a questionnaire, which is covering some systems like general medical, hematological, cardiac, and according to the results of this questionnaire, it's telling the patient, do you have this disease? Yes, no, yes, no. And if the patient has a score less than 59, so this patient can go under this procedure under an outpatient procedure. Also, regarding the American Society of Anesthesia classification, there should be, if the patient is SA1 or SA2, he can go for outpatient total knee arthroplasty. And the third index, which is Charlson Comorbidity Index, these are 19 morbidities, and every morbidity has a scoring 1, 2, 3. And if the patient has a score less than 2, so this patient can go to do this procedure as an outpatient procedure. The next question is this practice is safe? What is the proof that it is safe? If we check this systemic review, which studied 17 studies from 3 databases, the result of this systemic review says that there is no increase in readmission rates, and there is no increase in preoperative complications. Also, the high level of satisfaction of the majority of the patients. Also, we have another retrospective cohort study, which includes about 115 patients from 2015 to 2017. 46. This study was covering all total joint arthroplasties, like hip total hip arthroplasty and total knee arthroplasties. From these cases, from 115 cases, 46% of these cases was total knee arthroplasty. And in this retrospective study, it says that outpatient total joint arthroplasties with discharge to home as a freestanding is safe. Also, we have another supporting systemic review, which studies all the studies from 2000 to 2016. And it's a very big study, very big systemic review. It includes about 1,009 patients. And during this period, there was some complications like reoperation and readmission, which was a very small, you are speaking about 1.98%, and there was no death recorded. And the result for the systemic review, it says for carefully selected patient with experienced surgeon, in major centers, outpatient arthroplasty is a safe and effective procedure. So this review put in 3 conditions. The first condition is patient should be carefully selected. The second condition that the surgeon should be an experienced surgeon, and the third condition that the center should be a major center with good facilities. Also, there's another study which is comparing outpatient to inpatient cases regarding the range of motions. If we look to the numbers here, the mean range of motion of outpatients is 123 compared to the inpatient 121. So there was no difference between inpatient and outpatient regarding the range of movement of the knee. Also, we have another study, and this study has a questionnaire which attracted me to put in my presentation. This questionnaire was given to 51 patients who did one knee total knee arthroplasty as an outpatient, and on this questionnaire they asked them, are you willing to do the other knee on the same with the same technique like an outpatient? 96% of these patients they didn't mind to do it as an outpatient according to their previous experience. Also, this study is saying that this study actually used the American College of Surgeons for the cases done between 2011 and 2013, and this study actually found that there is some complication associated with outpatient procedures. And according to them, most of the readmissions was connected to bleeding. Actually, they didn't mention how much cases generally they are facing this complication to their patients, because bleeding is sometimes it's connected to the surgeon's technique, surgeon's capability to do the good hemostasis. So in their recommendations, they said we must focus on preventing post-discharge medical complications to include blood management strategies. And this one is a very big retrospective study which is done from 2007 to 2015, which includes about 4,000 patients done under outpatient and about 128,000 patients done this procedure under as an inpatient procedure. And according to this study also, they said the complication connected to the patients who did it as an outpatient is more than the patients who did it under inpatients. But if we look clearly here to the numbers, and the numbers of the patient, the complication of revision, you are speaking about 1.2 compared to 0.8, and also in the stiffness 4.2 compared to 3.5. DVT 2.3 to 1.4. So the numbers are not big numbers, but actually the p-value here was statistically significant. That's why this study is giving a result that the outpatient is connected with more complications if it's compared to the inpatient procedure. Also, we have another study which is in this tertiary center. They studied how many patients selected to do their operations as an outpatient, and how many of them they were successful to do it as an outpatient. For the patient who was going to do total knees, 88% of these patients selected pre-op to do it as an outpatient. They succeed to make them go till the end as an outpatient without complication. Also, as a in total hip, they succeeded in 69%. And the reason of failure of discharge in the same day was orthostatic hypotension, urinary retention, nausea, and the usual complications, which is not one of them is a serious complication. Lastly, there is another study which is comparing outpatients to matched patients. Matched patients means the patients who can go as an outpatient procedure, but they didn't go as an outpatient. They did it as an inpatient for another non-medical reason, like patient refusal or any other reason. And they compared the readmission ratio between the two groups, and there was no readmission to be related to outpatient. And if you look here, the matched group has more reasons of, on the left side, has more reasons of readmission than the patients on the outpatient. Okay, we have a good question here which says how to apply outpatient total knee. How to apply outpatient total knee? We have considerations: pre-operative, intraoperative, and post-operative. We'll start with the pre-operative considerations. In the pre-operative considerations, we start first how to select our patients. As we said before, we have three types of assessments: the assessment of ambulatory arthroplasty risk, the ASA, and the Charlson comorbidity. Which one of them I use them in my center? Actually, there was a study comparing the three indicators, and this study was retrospective on 1,120 patients, and the study said that the sensitivity of the assessment of ambulatory arthroplasty was about 81.6%, means 81.6% of the patients selected through these indicators, they succeeded to make them as an outpatient. Compared to the ASA was 56.4, compared to the Charlson comorbidity, which is 70%. So they advise that the assessment of ambulatory arthroplasty risk is the best indicator, and through this indicator you can select your patient. And as we said before, if the patient has a score less than 59, so the patient will be eligible to do it as an outpatient procedure. The next pre-operative consideration is the patient education. Patient education can be done with many methods. First, you can use flyers. Second, you can use patient educator in your hospital. Third, you can use the multimedia and the social medias. My preference is to use the social media, and I think this is the best way to do patient education, because the patients usually they are old age. They were not keen to read your pamphlet. Even in the meeting with the educator, they have a lot of things to think about. They think about when to go to the anesthetist, when to go to do their labs, when to do their ECGs. They will not focus well with the educator. But the social media, they can easily, through their mobiles at home, see some videos which educate them about their procedure and what they expect during the operation and after the operation. Also, the third consideration, the most important consideration, how to integrate their families. Their families should be integrated and should be engaged in the procedure, because the families are the ones who are responsible for the patient when he goes home. The family should be aware how to deal with the relative, how to what to do if the patient, if the relative needs help, when to seek medical advice, when to take the relative and go back to the hospital. They have to be educated for this. Then we are speaking about the preemptive use of opioids. Preemptive use of opioids, generally not in outpatient cases. They are proved in many trials. We have here 2 trials, which says preemptive opioids will help in managing post-operative pain, and it will reduce the post-operative opioids. Actually, in using the opioids, we have to be more cautious, because our patients are old patients, and if you give them oxycodone, it may cause some delirium, some respiratory problems. So preoperative opioids, you shall select your patient, who is the patient who can receive opioids and who is the patient who will not receive opioids, because of the side effects of the opioids. The second thing is the preemptive use of anticox-2. It's proved also generally, not for outpatient, not for knee cases, that they use anticox-2 before the operation will decrease the use of opioids, and also will improve the patient satisfaction. And with anticox-2, there is a lot of studies saying that pregabalin and gabapentin will have synergetic effects with anticox-2, and they advise to give it as a preemptive before the operation, as a medication before the operation. So usually you ask the patient to take anticox-2, like Celebrex or any other drugs, and we ask the patient to take Lyrica before the operation, at the night of the operation. It will help your patient very well after the surgery, and it will cause and it will make a better pain control. Now we will go for intraoperative period. During intraoperative period, the use of anesthesia, the most advised anesthesia is regional anesthesia, and specifically spinal anesthesia, because of the advantages which we all know, like lowering systolic blood pressure, reducing hemorrhage, and reducing pulmonary and CVS complication, and reducing nausea and vomiting. Then we will go for peripheral nerve blocks. Peripheral nerve blocks, there is a lot of peripheral nerve blocks we can use. We can use either femoral nerve block, adductor nerve block, adductor canal block, or we can use sciatic nerve block, IBAC block, which one we use to our patients. We'll start with the femoral nerve block. We see in this study, it's studying the effect of femoral nerve block on knee operations. And on the femoral nerve block, the study says that it reduces opiates 80% in recovery room and 40% in the first 24 hours. But there is some problems they faced in their patients that it affects the quadriceps motor power, which actually in outpatients we don't need this. We need the patient fully moving, fully muscle power. We want the patient as soon as possible, once the spinal anesthesia effect finished, start their physiotherapy, start moving their leg with active and passive movements. So femoral nerve block with the quadriceps affection is not a good choice in these patients. This video shows how we give the femoral nerve block. This is the femoral artery, and this one is the femoral nerve. We go with the needle from lateral to medial. We inject below the fascia iliaca. If you see here, this is the fascia iliaca. We inject above and below the femoral nerve. Then we'll go for the adductor canal. Adductor canal, there is a comparative study which comparing the casters inserted for femoral nerve block with the caster inserted with in the adductor canal nerve blocks. Actually, they find the efficacy is the same. But if we look to the femoral nerve block, we will find the femoral nerve block efficacy in the first 24 hours is more than the adductor canal block. Yani if we compare femoral nerve block efficacy to control pain in comparison to the adductor canal block, femoral nerve block is better than adductor canal block in controlling pain. But in regarding the quadriceps weakness, the adductor canal is better than the femoral nerve block because it's mostly sensory blocks. Not we are blocking the saphenous nerve. We are not blocking the nerve which is motor to the quadriceps. So the femoral nerve block is the adductor canal block is better in the result of this study says the limb mobilization in the first 24 hours is better in the adductor canal block. Also, there is some meta-analysis done for 8 randomized controlled trials involving about 702 patients. In this meta-analysis, they are comparing the adductor canal block. Am I going to give a single shot or I'm going to insert a caster? On this meta-analysis, for the Dr. Omar, before we start, there was some conversation that in our hospital we are putting casters, in this hospital they are giving only single shots. But in this meta-analysis, they say that the adductor canal block has an effective alternative to the single shot and can provide better pain relief, more degree of maximum flexion, and lower amount of opioid consumption over time. This is the adductor canal block, some small video. This is the superficial femoral artery, and we are going lateral to medial with our needle. Our aim to inject our local anesthesia at 7 o'clock to the artery. The next slide. Is it? Okay. Actually, in our department and in our clinical experience, we found a solution to get a good pain control versus not affecting the muscle power. According to my clinical experience, and we are doing a lot of cases in our hospital, I used to use ropivacaine 0.15 with adding adrenaline 1 to 200,000 as a femoral single shot on the immediately after the operation. And after this single shot of ropivacaine, I'm putting the adductor canal caster, which is providing pain control in the coming days after the operation. So 0.15 I never seen, because most of our surgeons, they are asking for day 0 physiotherapy, and I never get any complaint from physiotherapists saying that there is some weakness, the patient cannot control his weight, the patient cannot do flexion or extension. I didn't find any complaint if we are using this concentration. 0.15. 0.15 of ropivacaine is completely a completely sensory block and is not affecting motor at all. Now we will go for in the adductor canal. When we put casters, we can use electric pumps, or we can use elastomeric pumps. The elastomeric pumps is the best for patients who are going to as an outpatient, because you can send the patient home with elastomeric pump. And in our hospital, actually, we are using elastomeric pumps for short stay surgeries like ankle surgeries. We are putting nerve block casters, and we are sending patient home with this elastomeric pumps. And some of the new elastomeric pumps now have an option to give your local, like intermittent boluses, or you can use it as a continuous infusion. Then we will speak about the sciatic nerve block. Sciatic nerve block, in these papers, they are speaking about giving low concentration of sciatic nerve block will give better posterior pain control in the first 24 hours. But if you look here about the better motor weakness down in this table, in the first 6 hours, we are speaking about 16% of the patients will have foot drop. And in the first 12 hours, 8% of the patient will have foot drop. We want to discharge the patient as soon as possible. We cannot discharge the patient while the patient has foot drop. So sciatic nerve block also, if you are going to give a sciatic nerve block, it's not a good choice, because the patient, while he has a foot drop, he cannot start physiotherapy as soon as possible. And also, if we go back to this slide, they are speaking about low concentration of sciatic nerve block. The low concentration here in this study, they are speaking about 0.125 Markane. Okay. This is a small video to how we give sciatic nerve block. This is sciatic nerve to the left side. This is common prenatal. To the right side, this is sciatic. This is tibial nerve. And sign that we our block is giving well, that when we see both nerves are separating together with local anesthesia or given. Next, the IBAC block. IBAC block, the idea of IBAC block is that you are blocking the sensory nerves coming from the sciatic nerve to the posterior capsule of the knee. If we see here, this popliteal artery, and above the popliteal artery is tibial nerve, and the tibial nerve is giving sensory branches to the posterior capsule of the knee. The idea is to fill all this area between the artery and the posterior capsule of the knee, to fill it with local anesthesia. And we have two studies here. They are telling that the IBAC combined with adductor canal, it has a good results regarding the stay of the patient and regarding the use of the opioids. This is a video also showing the IBAC technique. In the middle of the screen here, you find the popliteal artery, and above the popliteal artery is the tibial nerve. You see now the needle is coming from lateral to medial. Down here, this is lateral epicondyle, and this one is the medial epicondyle. You are filling this area, all this area, with local anesthesia. I usually use 25 ml of local anesthesia. I put 15 ml between the artery and the posterior capsule, and 5 ml on the above the medial condyle, and another 5 ml over the lateral condyle. Okay. The same. Ropivacaine against bupivacaine. In my practice, I'm giving sciatic nerve block. I'm not giving IBAC. And the sciatic nerve block I'm giving also on with 0.15. And all my patients, without acceptance, after the spinal bone, I never see foot drop when I'm using this concentration. I'm using 25 ml of 0.15 ropivacaine with adrenaline, and it gives me a good posterior analgesia for at least 24 hours post-operative. Now the next technique is periarticular infiltration. Periarticular infiltration is a safe, simple, practical, and effective procedure, and we started to use this technique in our hospital maybe 5 or 6 months ago, and we find a very good results regarding controlling of pain. What we use in this periarticular infiltration, we use bupivacaine, we use some additives like adrenaline, magnesium, clonidine, and in clonidine we are giving from 75 to 150 microgram, and actually clonidine We observed that post-operatively, maybe 30 minutes after the operation, the patient start to have some slight hypotension. That's why we are trying to decrease our use of clonidine now. Also, we are giving sometimes dexamethasone, ketorolac, and morphine in this periarticular injection. And we are asking our surgeons to inject, as we see in the previous slides, to inject the local in the posterior capsule, and to inject everywhere. It will give a very good post-operative results, as you see in this video. Okay. You see all these drugs. All these drugs, there's some substitution to this drug, which is Exparel. Exparel is a long-acting bupivacaine, which is liposomal bupivacaine, and this drug can stay controlled pain for 5 to 7 days post-operatively. And the use of Exparel is how to prepare Exparel. The 120 ml of this drug is giving us 80 ml of injection, and the surgeon can use this Exparel for periarticular injections. And there is some
injection technique is quite similar.
And there is some trick in this. There is some trick in these injections that you have to inject the drug every 1 to 1.5 inches because this drug is not diffusing through the tissues. So the surgeon has to inject every 1 to 1.5 inches. Next consideration is tranexamic acid. The use of tranexamic acid is known to decrease the blood loss, and there is no relation to venous thromboembolism. And also using new techniques like robotic total knee arthroplasty. Robotic total knee arthroplasty is known to have less pain and known to have better outcomes to our patients. And in the post-operative period, we can use the continuous nerve blocks or long-acting local anesthesia like Exparel. And anyway, the Exparel is not available in Saudi markets, and we hope we can get it as soon as possible in our hospital and use it, and we will give you feedback about this drug. Opioids also, we can give the oxycodone, we can give COX-2 inhibitors, pregabalin, and acetaminophen. Post-operatively also, there should be physiotherapy started as soon as possible, and we advise there will be some home visits for at least 3 days post-operatively. In these home visits done by physiotherapists, done by pain management team, just to follow up for the next 3 days after the surgery, and if there is any assistance needed, it can be given at home. New innovations, there is some machine which is called Ayurveda. This machine is a new machine with, there's not a lot of publications about this machine. This machine idea, it's using cryoneurolysis, and the cryoneurolysis, it's like a genital nerve block using cryoneurolysis. And this machine, the only study done on August 2021, says it reduces opioids and in hospital pain and optimizing outcomes during the 6 weeks of recovery. And even the elite that you can control pain from 90 to 150 days, but still there is no
anesthetic superficially in the subcutaneous layer using shallow injections along the entire. A tone will sound
that's how we use the machine, and this machine is used
each
3
cycle
to 10
takes
days
60
before the
seconds,
operation.
and a tone will also sound when it's complete. When you see a check.
Actually, 2 days back, we had a conversation with Dr. Ronnie. It is like a virtual meeting with him, and he was giving us some idea about this machine, and we hope we can get this machine as soon as possible in our hospital, and when we get it, we will give you feedback about it. Take-home message, the outpatient total knee arthroplasty is safe and effective with carefully selected patients. Pre-operatively, we shall make good patient selection, patient education, patient family engagement, and preemptive use of opioids, preemptive use of COX-2, preemptive use of gabapentin and pregabalin. Intraoperatively, use of regional anesthesia, use of peripheral nerve block, use of prearticular infiltration, use of tranexamic acid, and new techniques like robotic TKRs. And post-operatively, multimodal analgesia, physiotherapy, and home visit. Thank you very much.